Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist. I've been in Houston practicing for 40 years. This is a series of lectures on heart health. The focus of presentation today is mitral stenosis, causes, symptoms, presentations, examination, tests, and treatment. So let us begin with the feature presentation. In this presentation, I'm going to talk about the definition of mitral stenosis. We're going to look at the various causes of mitral stenosis, what are the symptoms the patients present with, and what are the findings we can detect on physical examination, especially heart murmurs and cardiac palpation, electrocardiographic changes. Echocardiogram is the cornerstone of the diagnosis of mitral stenosis, the degree of mitral stenosis, the stages of mitral stenosis, and the rest of the structures around the mitral valve apparatus. Heart catheterization is rarely required in the present day with the advent of echocardiography, but there are certain circumstances where we may have to do a cardiac catheterization, which I will talk about. In the second half of this presentation, I'm going to talk about management of atrial mitral. In the second half of this presentation, I'm going to talk about management of mitral stenosis, particularly involving the treatment of atrial fibrillation if the patient has atrial fibrillation, and the need for blood thinners. We're going to talk about that. We're also going to talk about mitral valves, mitral stenosis and pregnancy. This is a very important topic, especially for young ladies who are planning to become pregnant if they have significant mitral stenosis. Then we're going to talk about some procedures that can be done, such as balloon valvuloplasty, which can be done percutaneously. Then we have open mitral valvotomy, and of course mitral valve repair or replacement, which is an open heart surgery. And we're going to talk about the management of heart failure, and finally look at the prognostic indicators. Okay, let us begin with the anatomy of the mitral valve apparatus. As you can see, the mitral valve separates the left atrium from the left ventricle. It consists of two semilunar leaflets which are connected to the two anterior and posterior papillary muscles through these fine cords which are like the threads of a parachute. The whole mitral valve apparatus and the tricuspid valve apparatus look like a parachute from the front to back. You can see these threads attached to the papillary muscles. Then these leaflets close and come in approximation when the ventricle is contracting, so there is no leak of blood into the left atrium. You can follow my arrow here. Is the atrium. And in patients with mitral stenosis, we see the thickening of these mitral leaflets, which are really paper thin to begin with. They become really thick, calcified, and fibrotic, so their mobility is severely restricted. Along with that, the chordae tendineae are also shortened, causing the mitral valve apparatus to become really stiff, rigid, and inflexible. As a result, there is a decreased amount of blood coming from the left atrium into the ventricle during the atrial contraction, leading to left atrial enlargement, then pulmonary congestion, pulmonary hypertension, and eventually right heart failure. Surprisingly, when patients have critical mitral stenosis with pulmonary hypertension, they have right heart failure and signs of right heart failure like hepatomegaly, leg edema, fluid collection. However, their ventricular function is preserved and the ventricular size is usually normal unless they have mitral regurgitation along with mitral stenosis. This is how a normal valve opens like a fish mouth, and when it closes, it approximates in this manner like a purse string opening. And in mitral stenosis, it becomes heavily calcified, fibrotic, all the edges fuse together, so the area becomes considerably less. When the area is less than 0.6 centimeters per square, it is considered to be critical mitral stenosis. Let's talk about some of the causes of mitral stenosis, the most important of which is rheumatic fever, which is generally seen in younger population following a strep throat infection. If they had a strep throat infection, you need to be cognizant of the fact that some of them can develop rheumatic fever, which later on leads to this rheumatic valve involvement, especially the mitral valve, the aortic valve, or the tricuspid valves. Let's go back here. It can involve the mitral valve, it can involve the tricuspid valve, it can also involve the aortic valve, where the valves become stenotic, and also eventually they may leak because of immobility of these leaflets. We have another form known as the congenital mitral stenosis that is exceedingly rare. We do not see that. It is usually seen in the pediatric population. In older patients with heavy amount of calcification around the mitral annulus can restrict the movement of the leaflets and also cause thickening and calcification of the leaflets, leading to mitral stenosis or features similar to mitral stenosis. Carcinoid is something that deposits these little nodules on especially the tricuspid valve. They can also deposit these nodules on the mitral valve leaflets, thus making the leaflets stick together, reduce their mobility, and cause mitral stenosis. Another condition that can cause is left atrial myxoma, which can intermittently block the inflow into the left ventricle, thus causing functional mitral stenosis. Let's talk about symptoms. Symptoms are mostly related to, let's go back here, symptoms are mostly related to the restriction of the blood flow from the left atrium into the left ventricle. Because of the restriction of the blood flow, there is the blood backs up into the lungs and causes pulmonary congestion, and also it causes the enlargement of the left atrium. So the symptoms may be related to the enlargement of the left atrium and pulmonary congestion, such as shortness of breath, weakness, fatigue, fluid retention, leg edema, palpitations because of this enlarged left atrium, having irregular arrhythmias, and atrial fibrillation is a common finding in patients with atrial fibrillation. So they can have palpitations and dizziness, and sometimes they can also have exertional syncope. Let's go back here. Chest pain, palpitations, weakness, leg swelling, weight gain, and syncope. So these are some of the most common symptoms of patients with mitral stenosis. Let's talk about physical examination. They say these patients have mitral facies, a face that looks like it's pinkish flushed skin. And I have not seen that one, but anyway, that's what the textbooks describe. And the apical impulse could be like a tapping apical impulse. It would just come and like touch the chest wall and retrieve back. We can feel the palpable first heart sound. It's not heat sound. I'm sorry, there's a typo here. Then the characteristic findings on auscultation are mid-diastolic click and mid-diastolic rumbling murmur with pre-systolic accentuation if they are in sinus rhythm. However, if they are in atrial fibrillation, the pre-systolic accentuation, which is caused by the atrial contraction, is not usually seen in atrial fibrillation. If these patients they have heart failure, they may have signs of rales and congestion in the lungs, hepatomegaly, and leg edema. Anyway, let's look at some of the features of heart murmurs, which can be a board question for medicine, cardiology fellows, and nursing students. Here we have the first heart sound, then we have the second heart sound. And here, after the second heart sound, we have the opening snap. As the mitral valve tries to open, it just cannot open because of the restriction and fusion. And so it creates a snap. And following that, we have a mid-diastolic rumble. And as the atria tries hard to squeeze the blood into the ventricle during the atrial contraction, we can have a pre-systolic accentuation. So we have an opening snap after the second sound. We have a mid-diastolic rumble, which is heard mostly at the apex, along with pre-systolic accentuation, but only seen in patients with sinus rhythm, because atrial fibrillation, you don't have atrial contraction of significance to cause the pre-systolic accentuation. Okay, and here is a summary of all the auscultation findings. Namely, we have apical diastolic thrill. We can feel we have an opening snap, loud first heart sound, and a low pitch. So we have to use the bell to hear that one. The mid diastolic rumble, loudest at the apex and radiating to the left side of the chest. Electrocardiogram may show some signs of left atrial enlargement, as you can see here. Actually, if you see a left atrial enlargement, as you can see in this insert box here, you see a biphasic P wave in lead 2, which we are supposed to be seeing here, but it's not very distinct. And in V1, we're going to see a negative deflection involving more than one square box. So that's suggestive of left atrial enlargement. We may also see some evidence of right ventricular hypertrophy in patients with pulmonary hypertension. Along with that, they may also have signs of atrial fibrillation if they have atrial fibrillation as such. Now let's turn to the echocardiography. Echocardiography is the gold standard for diagnosing the presence of mitral stenosis, the degree of mitral stenosis, the chamber sizes, and the function of the rest of the heart. As you can see, the mitral leaflets, because they are adhered together and they are not mobile, they dome. When you see this doming effect on the echocardiography, that is suggestive of mitral stenosis. When you look at the cross section of this mitral valve in this picture B, you see this heavy calcification of the mitral leaflet with the opening, which is like a very small opening. The normal opening is 3 to 4 centimeters square or bigger, but here it is like probably pretty significantly narrowed. Along with that, you can see the leaflet mobility is reduced. The left atrium is grossly enlarged. And in this patient, we also see some degree of mitral regurgitation along with mitral stenosis. And if you do a 3D echocardiography, you can actually see these anterior and the posterior leaflets sort of ballooning, and along with that there is restricted opening of the mitral orifice. The degree of mitral stenosis is determined by the Doppler studies, which measures the pressure half time, the time it takes for the pressure to drop, the velocity to drop by, pressure to drop by 50%, and that is used to calculate the degree of mitral stenosis. And here is another example with a mean gradient of 8 millimeters. That's based on this pressure half time. As you can see, the pressure half time is measured here in the mitral inflow Doppler. Here, with a lower gradient, we have a different morphology altogether. And this is 4 millimeters of gradient, mild mitral stenosis. 8 millimeters of gradient is a moderate mitral stenosis. Okay, cardiac catheterization is generally not needed to manage patients with mitral stenosis. However, if we are looking for significant mitral regurgitation, and if you want to look at left ventricular function, we can also look at other valve structures like the aorta and the tricuspid valve. We can also look at the mitral valve gradient by putting catheters in the left ventricle and in the pulmonary wedge position, thus getting the gradient to determine how significant the mitral valve gradient is, and based on that we can calculate the mitral valve area. If someone is a older patient, we may do coronary angiography to to make sure they don't have significant coronary angiograms before they are subjected to any kind of procedures. Okay, now let's switch gears and talk about mitral stenosis management. Okay, in the management section, we're going to be looking at treatment of atrial fibrillation, which, when it is present, needs attention. They may also need blood thinners, especially if they have atrial fibrillation and blood clots in the left atrial appendage, which I'm going to talk about in a few minutes. Then we're going to talk about mitral valve stenosis and pregnancy, because this is an important topic also, especially for younger females. When we talk about some interventions like balloon valvuloplasty, open mitral valve valvotomy, mitral valve repair, treatment of heart failure, and prognosis. So let us start off with if the patient, this is the left atrial appendage, as you can see by a two-dimensional echocardiography or TEE. This is a TEE, and here is a appendage which has no blood clot, and here's an appendage which has a blood clot. If you see the presence of blood clot in the left atrial appendage, there's a treatment we can do, what is known as the Wasserman treatment, where we can seal off this area. But if they are having atrial fibrillation and blood clots, they need to be on blood thinners. Most commonly used blood thinner is warfarin or Coumadin. That's something you need to be familiar with. And when we use warfarin or Coumadin, we have to adjust the dosages based upon the PT-INR. Next thing, let's look at balloon. Before we go into balloon valvuloplasty, let's talk about mitral stenosis and pregnancy. If someone has critical mitral stenosis, they should not be undergoing pregnancy, because the increased hemodynamic stress on the heart from the pregnancy can put them into heart failure, atrial fibrillation, and all kinds of complications. Also, if they have atrial fibrillation and if they are on blood thinners, pregnancy becomes more challenging, because the blood thinners have to be very carefully monitored, and patients are switched over to heparin during the mid-trimester, and they need to be followed by a cardiologist and obstetrician as a team. So if the mitral stenosis is mild, they should be able to go through the pregnancy, but this is something that needs to be thoroughly evaluated at a medical center with the experts, because as I said, you are not only subjecting the mother to a lot of stress, even the baby can be stressed because of the critical mitral stenosis. Now let's talk about balloon valvotomy. Balloon valvotomy is performed like a heart catheterization. You put a catheter in the right side of the heart through the veins, and you bring it across the atrium with a puncture needle, and the balloon is passed across this mitral stenosis area, the leaflets, and the balloon is inflated. This is during the cardiac catheterization. Yes, you can see the balloon is inflated. Once the balloon is released, it tears some of these adhesions, thus improving the mitral valve area, but it may also cause leak because these leaflets are not very mobile. But I think opening of the mitral valve may be more important than a small amount of leak, which can be easily managed. This is like an open heart surgery where they use an instrument to pass it across the mitral leaflet openings, and it has little prongs which are spread apart. It's the same way as the balloon, except it's done from the left ventricular puncture here. And this is during open heart surgery. All right, this is another balloon valvotomy. I don't know why it came second time. Anyway, let's continue with this. And here is a left atrial appendage closure device. This is known as the Wasserman device. There are other devices also. Again, this is done through the right heart catheterization. A catheter is passed into the left side of the heart, into the left atrium, and the left atrial appendage is isolated using echocardiography guidance. From that place, this umbrella-like structure is placed into the left atrium, as you can see here, and that seals off the left atrium, and thus no clots can come through the wire mesh, which is kind of sealed off with the development of the endothelial cells. And this procedure can help patients to get off warfarin or Coumadin. There's another procedure which is done through an incision in the skin, where they come and clamp this left atrial appendage, but that's sort of a semi-surgical procedure. So ladies and gentlemen, this is a very quick overview of mitral stenosis, definition, causes, symptoms, presentations, examination findings, diagnostic studies, and management. I hope this has been useful to you, and please do subscribe to our YouTube channel, and I will see you in the next presentation. We have more than 200 topics on cardiology. You're welcome to watch them, and please do subscribe to our YouTube channel, and I will see you in the next video.